Today's topic is class 2 malocclusion. We will deal with what is the class 2 malocclusion and what will be the management of class 2 malocclusion in detail. The contents includes the introduction, classification, etiology, clinical features, treatment modalities, conclusion and reference. Edward H. Anker, the father of modern orthodontics, he said that evenly placed row of teeth arranged in a graceful curve with harmony between the upper and lower arches. This is the definition given by E.H. Angle to normal occlusion. We know that Angle classified the occlusion into three types: class 1, class 2, and class 3. Class 1, as the picture says, the mesiobuccal cusp of the upper first molar occludes on the mesiobuccal groove of the mandibular first molar. This is the class 1 occlusion or class 1 relationship. Into the canine, the mesial incline of the upper canine occludes with the distal incline of the lower canine. This is the Angle's class 1 canine relationship. Moving into the class 2 malocclusion. In class 2 malocclusion, there will be a distal relationship of the mandible with respect to the maxilla. The mandibular arch will be distally or backwardly placed with relation to the maxilla or the cranium. So, the distobuccal cusp of the maxillary first molar occludes on the buccal groove of the mandibular first molar. Okay. This class 2 malocclusion can be broadly divided into two categories, that is the division 1 and division 2. These are the clinical features of D1. In D1, the maxillary incisors will be proclined. As the picture, we can see that maxillary incisors are proclined. Because of this proclination of the maxillary incisors, there will be increased overjet. As the lower mandibular lower incisors doesn't have any counterpart, it will extrude, and which results in the increased overbite, okay, or debite. So these are the features: increased overjet, increased overbite, and there will be constriction of the maxillary arch. In D2, apart from the D1, the maxillary incisors will be retroclined, and there will be a labile tipping of the maxillary lateral incisors. This is the subdivision classification of the D2. Here we were talking about the dental class 2 malocclusion. If this dental class 2 malocclusion have a skeletal base, we call it skeletal class 2. Skeletal class 2 can be of three types. First, the class 2 may be due to the prognathic or forward positioning of the maxilla or prognathic maxilla, or normal maxilla with a retrognathic mandible. The mandible will be backwardly placed, or retrognathic mandible. And the third condition is the combination of both, that is the prognathic maxilla and the retrognathic mandible. In picture we can see, because of the small size of the ramus and body of the mandible, downward and backward rotation of the mandible occurs. We can see the mandible is backwardly placed and the maxilla is forwardly placed, and there is a downward and backward rotation of the mandible, which also gives rise to a skeletal class 2 relationship. What are the dental compensation? If the mandible is retrognathic or backwardly placed, there will be proclination of the mandibular incisors. There will be constriction of the maxillary arch. There will be mesolingual rotation of the maxillary first molar. These are all the natural dental compensation for a skeletal class 2 malocclusion. The Moyers classified into horizontal class 2 and vertical class 2. Types. Let's get into the etiology. What are the reasons, causes of this skeletal malocclusion or this class 2 malocclusion? Maybe hereditary, most commonly maybe a hereditary, genetic, Genetic factors, the genes have the program of the skeletal class 2. And patient have a skeletal retrognathic mandible or underdeveloped mandible, which results in a skeletal class 2 malocclusion. There will be a developmental defects, maybe, and there may be a trauma at the time of birth injuries such as EMJ ankylosis and forceps delivery, history of a forceps delivery, postnatal trauma, the physical age, the premature loss of the upper second deciduous molar may results in the mesial shifting of the upper first molar, which may give a class 2 relationship, molar class 2 relationship. Maybe premature extraction of this upper second deciduous molar or a impacted canine, which results in the shifting of the forward shifting of the upper segment, posterior segment. Habits such as thumb sucking, tongue thrusting, nail biting, and the systemic diseases, malnutrition, various causes. Let's come into detail into the clinical features. How can we identify if a patient comes to the clinic? We can identify this patient has a class 2 relationship or a class 1 relationship. What are the features, clinical features of these class 2 D1, which is class 2 D1, the most common among the class 2 malocclusion. First, the patient has a convex profile. The poems in echo, when you join the echo poems, it have a convex profile. The patients have a deep mandibular sulcus because of the mandible is retrographic. A deep mandibular sulcus and a hypotonic upper lip is the one of the most common feature of the upper incisors are forward proclined, see an increased overjet. Because of the upper lip is hypotonic, it doesn't have a tonicity. And because of this increased overjet, the patient tends to place the lower lip between the upper and lower incisors, which we can say as a lip trap condition. Lips may be incompetent or competent in this situation. And what are the coming into detail of the muscle activity? I said that there will be hypotonic of the upper lip, and another feature is the abnormal buccinator activity. Because of the buccinator is abnormal, it will constrict the maxillary arch, and the maxillary arch will be constricted or V shape. Apart from this, there will be hyperactive mentalis. These patients have an hyperactive mentalis activity. Coming into the intraoral feature, clinical features. First of all, there will be a class 2 molar relationship. Then as I said, there will be a proclination of maxillary incisors, flaring, V-shaped constricted arch, deep palate, deep curvosity. Due to the deep bite, there will be extrusion of the lower incisors. So I discussed that normal buccinator activity, lower positioning of the tongue. As we know, in the buccinator mechanism, the tongue muscle is balanced by the orbicularis oris buccinator and the superior constrictor. The whole band is balanced by the tongue muscle. When the tongue takes a lower position, there will be constriction of this buccinator and it will constrict the arch, and these constrictions can be seen in the premolar region because this balance is disturbed, and which can result into a posterior crossbite. We can say the hyperactive mentalis muscle. Coming into the extraoral features of the class 2 div 2 malocclusion. Class 2 div 2 malocclusion extraoral features are slightly different from the div 1. It may be or may not be a convex profile. It may be straight or a convex profile. And the lower anterior facial height will be reduced. There won't be any downward and backward rotation of the mandible. And the mandibular sulcus may be normal or deep. The iconic feature is the backward path of closure in class 2 div 2 malocclusion. In intraoral features, we can see a class 2 molar relationship. As I said, the maxillary incisors will be retroclined and the lateral incisors will be proclined, and the overjet may be or overjet may be decreased. There, because there won't be increased overjet because of the lingual tipping of the central incisors. The overjet may be decreased, and the arch will be a U-shaped arch. How will you diagnose? What are the other? I said the clinical features is okay. And other than that, first of all, we take a that's the essential diagnostic. First is the clinical taking the history, case history. Then clinical examination, that is the external and oral examination. And the third one is the study model. Then the photographs and the cephalometric radiographs essential. Into detail is the study models. Photographs, same features we will discuss. I'm not going into the details of the set values and we can directly come into the treatment modalities. That is the hardcore part of this management of this class 2. Class 2 malocclusion. The treatment can be broadly divided into growing patients and non-growing patients. Growing patients, we can give growth modification approaches. If the patient is non-growing, we have only two options. First one is the camouflage orthodontic treatment. That's the way the patient will undergo a camouflage. That is a fixed orthodontic treatment with or without extraction. And the other one is the surgical treatment. So let's focus into the when a class 2 patient comes, which is a growing patient comes to us, what are the different treatment modalities? First one is the orthopedic appliance headgear. Headgear is commonly used in a skeletal class 2, and the mandible is normal and the maxilla is prognathous. So when the maxilla is prognathous, we give headgear for the backward positioning of the maxilla or the maxillary arch. Headgear can be also used if there is not only a forward positioning of the maxilla but also a vertical growth of the maxilla is present, what we call as vertical maxillary excess. The most common feature of this vertical maxillary excess is the gummy smile. So in this case, we can give a high pull headgear. That's the occipital headgear. When we give a occipital headgear passing through the center of resistance, there will be backward and upward positioning of the maxilla, which results in the forward and upward rotation of the mandible. It also helps to reduce this gummy smile because the maxilla is upwardly and backwardly placed. What are the different parts of headgear? It's the face. The different types, J-hook headgear, face bow. The different parts is first one is the face bow. Face bow has an inner bow and outer bow with specific dimension. And the cervical attachment or neck trap. And we have a fossa mat. Is here we can see as a cervical headgear because in cervical headgear the support is taken from the neck. In the occipital headgear, as the name indicates, the support is taken from the occipital bone. So occipital headgear is commonly used if the patient is a vertical growth pattern. Maxilla is forwardly placed and vertical growth pattern, or the patient has a vertical maxillary excess. We can directly go for the. If the patient is horizontal grower and these conditions apply, that is a prognathic maxilla, horizontal growth pattern with normal mandible, we can go for the cervical headgear. That is the support is taken from the neck. Because in cervical headgear, not only the maxilla is backwardly placed, there will be extrusion of the maxillary posteriorly, which results in the opening of the bite. Let's come into detail about the force. How much force is required? So commonly asked question. Headgear requires 400 to 600 gram of force per stride. It's not complete. 400 to 600 gram of force per side. And the duration the child wants to wear, it is 12 to 16 hours per day. What's the time? The most active period of growth is before the eruption of permanent teeth. That is when we look at the CVMI stage, when the CVMI stage lies in 1 and 2, it's the most accurate period for giving orthopedic appliance. CVMI 1 and CVMI 2 is the most accurate period. And the result obtained would be a good, and lapse chances are will be very minimal at this stage. Headgear normally should be worn at the night as active growth occurs at this time. As we know, night time, the growth hormones, the release of the growth hormones and activity is more. So we prefer that one. What are the skeletal effects of this headgear? It compresses the maxillary sutures, it restricts the forward and downward maxillary growth, allows normal mandibular growth. The dental effects prevents the downward and forward eruption of the maxillary molar, indirectly enhancing the mandibular growth. High-pulled headgear, as I said, it has an intrusion effect on the mandible. If the patient has a vertical maxillary access or vertical growth pattern, this high-pulled headgear or occipital headgear causes intrusion of the upper molars, which results in a downward and upward rotation. Upward and forward rotation of the mandible, closing the bite and reducing the angle. Now we can go to the next condition, that is the normal maxilla and the mandible is retrognatic. Skeletally, the mandible is undergrown. Maybe if the mandible is retrognatic or backwardly closed, there are two conditions arise. One may be the anatomically short mandible, and the other may be backward positioning of the mandible in the condylar region. Retroposition to condyle. And the third condition is the functionally backward positioning of the mandible. Out of these three conditions, the most highest prognosis goes to the functionally backward position of the mandible. It stands first. And the second is the anatomically short mandible that responds to the this functional appearance. And this retropositioned quantile is little, the prognosis is little poor, and these patients have a high saddle angle. Let's go into what are the different removable functional appliances commonly used are as activator, bionator, FR2, tin block. Okay. If we prefer the fixed myofunctional appliance, we can go for the Herbst appliance, Jasper Jumper, Mara, and what are newer. Nowadays in market we are advancing to Forces appliance. You can go if the patient is in the late growth. Patient has a late growth, you can go for fixed myofunctional appliance. What are the indications of this functional appliance? First one is the active mandibular growth. The mandible should be deficient. Normal maxilla should be normal. This is the activator. We know the first myofunctional appliance by the Vigo, Anderson, and Carl. Different types modifications. Bionator by Balter. Is that far true? Is the fixed myofunctional appliances. He is coming to the fixed orthodontic treatment. If the patient, the skeletal problem, class 2 malocclusion comes to a dentist or an orthodontist at a stage where the growth is completed, and we can't give any orthopedic or myofunctional appliance. We have to think of have only two options. First one is the fixed orthodontic treatment, and the other one is the surgical. We can do a camouflage treatment. Camouflage treatment again with extraction or without extraction. That is the mild skeletal problems. We can go for this class 2. We can go for all 4 extraction, upper 4, lower 5 extraction. Class 2, upper 4, lower 5 extraction is a good option because the mandible, if the crowding is very less and it is well aligned and we have to correct the molar relationship, we can take the 5 and the mesialization of the lower molars. If we go for a dental camouflage without extraction, we can go for distalization. Distalization of this maxillary segment with various appliances such as headgear, Jones jig, pendulum appliance, distal jet, echo appliance. Various appliances are there. We can do it with implants. That's the distalization of the maxillary first molar. That will and the distalization of the distalization of the whole maxillary arch. Distalization of the whole maxillary arch can be done by extract the third molars and distalizing the whole arch. It has a dual benefit. First one is the reducing the overjet, and the other one is the coming back to the class 1 molar relationship. That's the derotation. One is the distalization, derotation of the molars can be done by TPA transpalpable by activating the TPA. The headgear using class 2 elastics. These are the different modalities of camouflage treatment, pendulum appliances, the extraction. Let's come into the last option, that is a surgical option. In a skeletal class 2 problem, if you have no remaining growth potential, no growth is there, and the skeletal problem is very large, the value, if you go for a self analysis, the values are very large. We have only one option, that the taking the surgical option. Conditions: if the maxilla is forwardly placed, prognatic, and mandible is normal, we can go for default one with setback. If the maxilla not only is forwardly placed but also vertical maxillary access, we can go for default with superior impaction and backward be setback also. In case of mandible, we can go for the advancement of the mandible with BSSO, that is the bilateral sagittal split osteotomy with advancement for the surgical options. As we know, surgical treatment always go hand in hand with the ortho treatment. That is the first we have to do a pre-surgical treatment, then surgery is done, then the post-surgical orthodontic treatment. Pre-surgical orthodontic treatment, we do the compensation. The decompensation is done. First in skeletal class 2, compensation has been happened. We will do decompensation. It will show that the malocclusion may worsen. You have to convince the patient first and go for surgery, and for settling and go for the post-surgical treatment. It's a different treatment, bilateral surgery, split osteotomy, developed by Richard Toner and Hugo Obergesser. In mandibular total subapical advancement, maxillary is the impaction, that is the upward placing. Anterior maxillary subapical setback for backward position of the maxilla. So in conclusion, class 2 malocclusion are very common malocclusion with characteristic features, clinical features. Excellent cephalometrics are useful aids for the diagnosis of such class 2 malocclusion. The treatment of the class 2 malocclusion depends upon the age of the patient and his focus, skeletal discrepancy, if any, and other skeletal factors. This should be taken into consideration before starting with treatment. Thank you. Thank you. Hope you have skeletal knowledge of the class 2 malocclusion and its management.